let me introduce Dr. Pena. He's going to be discussing non-invasive assessment of CLI, ultrasound, CTA, and MRA. A lot to do in 7 minutes, Dr. Pena.
I'll try my best.
But you can do it.
First of all, it's a pleasure to be here. These are my disclosures. So non-invasive assessment of CLI, and I think when we look at and ask this question, really what's the goal? Why do we image patients with PVD and CLI? And I think it's important that there's different questions that we ask. Sometimes we're just differentiating between vascular and non-vascular symptoms. Sometimes it helps us with after we have a physical exam and a good history, to assess the extent of disease and help us and get the anatomy, the level of disease, so we can decide treatment. This is an interesting graph because I think it's important. It dovetails on what Dr. Jaff said, and that is, I think when you do imaging is because you're considering revascularization. And I think morphologic imaging with CTA and MRA is important to help us make that determination and distinction. This comes from that similar guidelines paper that he showed from last year. And basically, when you're looking at patients with suspected CLI, the ankle brachial index could be helpful, but we know that in a lot of these patients, vessels are non-compressible, so we do need a TBI or tibial brachial index to help us, toe brachial index to help us. But at the end of the day, if you're considering revascularization, assessment with duplex ultrasound, CT, and MRA are really essential to help us make that distinction. When you look at the non-invasive examination, I look at this in 3 or 4 parts. First, an ankle brachial index, then using PVR with segmental pressures. A lot of times this will have 12 cuffs. If we're looking at toe PPGs in these patients with CLI, it's very important to help assess each of these toes. Then exercise, in particular in patients that can and don't have any contraindication. And then the Doppler ultrasound examination, the duplex, to help us get that map. So I think that really comes all together in that non-invasive examination, which I think is really the first thing and where we start to then decide what kind of patient we're dealing with, how many levels of disease, and are we thinking revascularization? Is it necessary in this particular patient? And then consider then a CTA or an MRA. So how does a CTA and MRI help us? I think it's important to help us with a treatment map. It gives us an accurate idea of where we're going, not only to help us plan our treatment, but to better prepare the patient. I think we need to understand and be able to explain to the patient what we think the risk of our procedures are, and make sure we have available tools for that particular patient to help us, to assess where are we going to access the patient. Is this something that will require a hybrid type approach with a surgical cut down, or maybe a radial type approach before we start getting into the lower extremities. So here's a great example of a patient with an aortic occlusion. This type of CTA helped me get an idea, what do I need to tell the patient? What type of revascularization procedure are we looking at? Is this a surgical case or an endovascular case? And really assess those risks and be able to basically triage and decide what to do. If you ask me the question why I do it, I think it's less risky to my patients than an angiogram. There's less radiation, obviously, to me. Easier to order and obtain a CTA and MRA to get that information. And then I can manipulate that data, because these are isotropic value data sets. Really get an assessment of a stent patency, the vessel wall, the nature of a vessel, to help determine what type of treatment and how difficult is it going to be to perform that revascularization. And I think that's really an important part of performing these examinations, being able to get as much information as you can. Here's a particular patient that had a bypass, a distal popliteal bypass, and you can see here on CTA and how well correlated to the type of angiography. A paper was written looking at if we had a CTA and we compared it to diagnostic angiography, how well do we do at triaging that patient to surgery or endovascular procedures? And basically showed the CTA does very well in this particular group. In a more clinical example, here's a patient, 65-year-old male, severe claudication. You're going to go ahead and revascularize and treat this patient due to his lifestyle-limiting symptoms. But a CTA shows you that those common femoral arteries are basically rocks. These are patients that you need to perform a hybrid type approach. This patient's going to go to surgery if they have a limited common femoral artery approach, or we're going to work together in terms of a surgical endarterectomy and then dealing with any other treatment. Here's another patient that has ulcers in the left foot. The CTA showed us severe iliac disease, but also some common femoral artery disease. This is someone we were able to discuss together as our team approach, and we decided in this particular approach, other than a hybrid approach, we were going to start with a right up and over approach, treat that iliac lesion, and see how that patient did. And this patient did quite well, as you can see here. Here's another patient with tibial disease. CTA allowed us to not only see what was open, but how calcified a lesion was. In this particular patient, we felt it was a focal lesion, was resistant to angioplasty. We went ahead and the second time treated it with a rotational atherectomy and then low pressure treatment with angioplasty. The problem with these patients with diabetes is really that we're dealing with very calcified patients, calcified arteries, CLI, you have a high risk of obstruction and a lot of occlusions. And I think this is the limiting factor also when we look at CTA and evaluating these challenges. You show these patients of the pedal arteries. How often do you see pedal arteries in a CTA? Very rarely. Usually they're normal patients. When we're looking at our patients with CLI, these are calcified vessels, very diseased vessels. It really limits our evaluation with CTA. Regardless of how well we bolus, how great our machines are, they're 256 or 512 slices, it's very difficult to acquire the right timing. Additionally, these patients are renally challenged. So it makes CTA in these particular patients very limited. What we like to use in these particular patients is MRA with time-resolved imaging, almost 4D type imaging. Allows us to evaluate the flow of these tibial vessels to get an idea how the flow is going and really the status of these vessels. The limitation is it doesn't really tell us information about the calcium in these vessels, but it allows us to then plan our therapy. So in this particular patient, what we could see with this type of flow is that there was a focal lesion in that tibio-perineal trunk. We then went and saw in the angiogram very similar to what we saw in the MRA and was able to treat it. This type of hybrid type approach where you have a station of the aorta, the SFA or the thigh station, and then a time-resolved station of the infrapopliteal station of and then the patient's lower extremity runoff is very helpful to help assess these patients so we can really come up with a good map of treatment. When you're looking at the decision, when do I get an MRA, when do I get a CTA, I think it's important to assess the patient's renal function because the patients that are renally challenged cannot get MRA contrast agents. At the same time, patients may not be able to get CTA, however, you may be able to hydrate them and prepare them and at least get some information of the aortoiliac segment and of the femoral vessels. The disadvantages of MRA, again, it's that renal dysfunction, that inability to see calcium, and patients that may have defibrillators and other metal. That leads us to really non-contrast sequences, and that's really where we're going, using non-contrast sequences to be able to obtain good views of the, hopefully, distal vessels. We're also looking at new contrast agents, so off-label use of iron oxides, and that's where things are going. So the value of MRA is really looking at the tibio-pedal evaluation. So you can see these examples where you can see, as a volume of information, being able to see that tibial station, but also being able to look at tibial vessels and see what the flow is in this particular patient in DP. So how do I choose? Calcified vessels, particularly in diabetic population, I favor MRA over CTA. So if I can get a MRA, I'll go ahead and get that. Particularly, I try to get my time-resolved imaging. So I think this is what's going to help me. A lot of times, if the patients are renally challenged, I can only give a certain amount of gadolinium. I'll use that contrast agent just to look at those tibial-pedal vessels. But again, CTA gives me that high spatial resolution. So if I'm able to do everything, I may start with a CTA and try to get that information from that study. Again, non-invasive imaging is critical and complementary to our physical examination and history. CTA and MRA helps us get that map, and I prefer MRA in our CLI patients. Thank you very much.